Hey there, Dr. Regan. Just wanted to go over this all-on-4 case that you had inquired about. This particular image or video is excluding all of the other in vivo tools, just because I wanted to leave his name out of it. So if it looks different, that's why. But in a nutshell, what I wanted to do was walk you through how I go through an assessment of a case like this. I actually do the same thing with a full mouth rehab case where I'm looking at the apices of teeth. But what I'll do, I want to create a coronal view where I can see all of the bone of interest in the arch of interest. So I'm always going to start with the upper arch. So I'll take this orange line here and I will approximate it somewhere on the ridge so that my coronal view will show me more or less the alveolar ridge. Then I will align the dots to maximize the focal trough. I've already done this, so that's why I'm not having to make many changes. When you do this, you're going to notice that you make more changes. But in essence, you create the focal trough of interest so that you get a panoramic view of something that replicates a pan. Not really our goal to make it look like a pan. Our goal is to be able to see what's going on. And then I will slide the green line over and I will look at the axial slice here. Normally it starts something like this, but I'm only going to look at one arch at a time, so I will zoom in. That's double clicking, you can do that, but I like to have all three views. And then I will center the arch I'm interested in and the anatomy superior to that or inferior for the lower arch. So the goal is to not have too much information in front of you so that you can really focus on the area that you're looking at. And then I will take the green line and I'll slide it from right to left, no different than when we're doing perioprobing. And I'm looking at the axial slices here. I'm trying to get a sense of how much bone there might be for implants. I'm also looking for sinus pathology, odontogenic pathology, so on and so forth. As you can see, we approached that first implant. I do think we have enough bone to place an implant posteriorly. I think one of your questions is, where do we place implants for an all-on-4? Where you can. The all-on-4 concept was invented as a graftless solution for an upper and lower fixed prosthesis. Graftless meaning it's sometimes difficult to do large grafts to get enough bone to place implants. There's a large amount of time and money associated with that. So the all-on-4 concept is the idea of tilting the posterior implants so that you can avoid the maxillary sinus, and on the lower arch, the mental foramen or foramina, to get as far back as you can without grafting. Now, there are cases where you don't need to do that. We still call it the all-on-4, but just know historically the all-on-4 concept, as developed by Palomalo, was designed to be a graftless solution with tilted implants. But all of the concepts that came out of that work apply here. We just place implants where we can. So, do I think we can place an implant back here in the upper right? Absolutely. Fortunately, that's really the only good bone he has in his upper and lower jaws. So I like that first implant. We can place one or two posterior to that. But as we come across the front, we start to see thinning of the alveolar ridge. Now this particular site right here, yes, we can reduce the ridge, and oftentimes we will do that. But how much bone vertically do we have as we engage the floor of the nasal sinus? 9 to 10 millimeters. I do think that's a possible implant. I wouldn't graft this site for that reason alone. But as you will see, most likely we're going to have to graft the other side, so we might as well graft this side too. We should talk a little bit about when we actually need to cut bone, not because of implants, but because of prosthetic space requirements. That will come out of the prosthetic workup later on in the case. Here we're just trying to get an assessment of what it's going to take to get this patient some implants. So as we cross the midline, we can start to see there's quite a bit of a deficiency on that left side. I don't think we can place an implant here without grafting, at least not predictably. So we have about 4 millimeters of width. Yes, according to the densiburs, we can place implants in ridges that are equivalent to the width of the implant we plan to place. Therefore, if we plan on placing a 3.8 millimeter implant, we can place that in this ridge. With that said, just because you can place an implant somewhere doesn't mean it's going to have a long-term success. I like the idea of having ideally 2 millimeters on either side of an implant. That's a goal, not something we often see. But we have to add this into our decision-making process as we decide whether we can place an implant there or not. I think we're starting to see that we'd be compromising this case potentially if we try to squeeze implants everywhere. Without a doubt, if you place these implants and you took a pan and the patient had the fixed appliance for 4 or 5 years, you might consider that a success. But then 10 years later, all the implants are failing because of bone dehiscence on the facial. We can't guarantee that's going to happen, but these are the things we need to think about if we're going to have a patient paying 25, 30 grand an arch. So I'm going to come posteriorly even more. We can start to see the bone thins out very significantly on the left side. So right about there, that looks like the number 12 site. Do we have enough bone to place an implant here? That's better. 5 millimeters is kind of nice. A 3 millimeter implant with densification would definitely be something that we could do. But that's really the first site since number 6. We need at least 4 implants, and we kind of want to have something somewhat anterior to the canines because of the cantilever forces that would be created as a result of not having implants in the anterior. So can we place 4 implants here? Potentially. Do I think it's a good idea? No. And I think you were spot on. As I'm coming around, his sinus is full. So a couple things we can do here. One is just refer to the oral surgeon and get clearance. Another one is take a CAT scan more superiorly so that we can capture the osteomeatal complex, which is the drainage port of the maxillary sinus, which is located up in this area. If the patient is not draining, I don't think we should go through and do surgery on these patients until they're cleared up. Sometimes it's just a matter of getting them on an allergy medication. Sometimes it's a sinus surgery. And there's Beckett. Hey, buddy. All right, so now that we've looked at the upper arch, I will then take the axial slice and then move down to the lower left. Again, just like we do with perio probing. And now I'm going to come across from lower left to lower right. Again, the goal of an all-on-4, as it was originally devised, was to place a tilted implant anterior to the mental foramen so that we don't have to graft posteriorly. But sometimes the patient has enough bone in the posterior, in which case, why would we tilt an implant if we don't have to? Yes, we can tilt implants if we split them together. That is the beautiful thing that came out of the All-on-4 concept, but we don't need to do that. We also don't need to place 4 implants. We can place 30 implants if we wanted. The All-on-4 treatment protocol is a concept, not a number of implants. The problem with this case, as you identified, very thin ridge. I can't imagine what surgeons did back in the day when they saw this much bone on the pan, got in, and then saw this little sliver of bone in reality. You can place implants here. They'll integrate. But you better have very good soft tissue adherence to the outside of the implant for long-term stability of the implant itself. That is one of the reasons why I like the BioHorizons implant, because it is designed for soft tissue adherence. With that said, that's something I want to rely on in a worst case scenario. In situations like this, I don't know what the answer is. The grafting, onlay grafting of some sort to get us where we need to be, not relying on soft tissue adherence to an implant. What is our width here? We almost have 5 millimeters. Very good, dense cortical bone. But that's in the number 27 area, it's just pretty thin all the way around. So this will be a tough one. One solution would be to do some ridge splitting with the osteo-periosteal flap. We can go through that procedure. Super technical. I love the idea. I do think we could pull it off on a case like this because the patient has good cancellous bone in the middle. The success of a ridge split, in my eyes, is contingent upon how much cancellous bone you have in the middle. If you have a significant amount of cortical bone, there's less vascularity there, you're going to be splitting something that's non-vascular. How is it going to grow in between? And the second thing is, how do you fixate these two together? But the osteo-periosteal flap is a technique that solves a lot of those issues. The question is the patient patient enough? And will he forego wearing a lower denture while that heals? I can't speak on whether a denture on top of a ridge augmentation of that complexity would be good or not. That's probably something we'd have to look in the textbook that I have on that particular procedure. With that said, the final option would be mini implants. Mini implants are non-osteo integrated implants. They have a low-grade titanium component to them. Therefore, they do not integrate into the bone, but they're not likely to break. Why do we have mini implants of that material? Well, the reason is conventional grade titanium is brittle at 3 millimeters or below. In other words, they're likely to break. The material has to change. It has to be more malleable and bendable and flexible. That's where they created the mini implant alloy. The problem is that alloy does not allow osseointegration. Therefore, if we're to place mini diameter implants in here, we have to let the patient know these will not be integrated. We run the risk of them simply just falling out. With that said, there's dentists that only do mini implants, and they're very good at them. It is a treatment modality that has success, but there's a large learning curve with it, and I do think the success rate is much lower than conventional implants. With all this said, BioHorizons has a 3 millimeter implant that has been shown to be very strong over the long term. I do think that we could potentially just use those here. I think that would be the simplest way to go. So that's the tour of the mouth using the CAT scan. If I had to say, we would do upper ridge augmentation, place some mini implants so that he could have a palateless denture that is retained by the mini implants while the ridge heals. That also takes the pressure off of the ridge. The lower arch, we can place 3 millimeter wide BioHorizon implants. Because they are narrow, I would place as many as you can. I would say probably 6 to 8. They would be somewhat close to each other. There'd be a couple that are angled, but that increase in surface area of implants would compensate for the fact that they're narrow, taking the stress off any one of the implants. We would spend extra time in making sure the occlusion's good, so none of the implants are receiving excess occlusal forces. After the upper is healed, then you would go through and do your conventional all-on-4, all-on-6 on the upper arch with conventionally sized implants. All in all, that would be, pretty expensive case, 60, 70 grand. I don't know how old this guy is and what he's looking for, but that would be ideal. Anything short of that would be just dropping in implants where you can and keeping our fingers crossed. All right, bud, I hope this helps, and I look forward to working on this case with you further. All right, take care.